afternoon, everybody. We're going to get started here in a moment. We got some people still filing in, but please grab a seat. There are still some available here. And as everybody's filing in and finding a seat, I will introduce myself briefly. My name is Doug Wolfberg from the firm of Page, Wolfberg & Worth. Joining me this afternoon is my partner in law. You thought I was going to say in crime. Steve Worth, who you'll be hearing from for the second half of the presentation. We're going to tag team this, and I'm going to start us off. We have a ton of material, so we're going to go ahead and jump into it. We have to, of course, do the self-deprecating lawyer jokes. Am I searching for the truth? Don't be silly. I'm a lawyer. So do we have any other lawyers in here? I know we have a couple. Any who like to self-identify as lawyers, the brave few? Well, here's some other good lawyer humor for you. Well, you were convicted on 3 out of 10 counts. At least we beat the point spread. So if your lawyer tells you that after your case, you need a new lawyer for your appeal, apparently. This slide says that all this material is copyrighted. If you're going to steal things, do not do it from a law firm. This says that this is a educational session, not a privileged and confidential attorney-client communication. So while we welcome your questions, please underscore when you ask them, say, hypothetically speaking, or something like that, and we'll be happy to try to address them in the time we have. And do you, Jennifer, promise not to interrupt the ceremony again to check your email? This is almost what society is coming to. This is the slide to remind me to ask you that if you have a cell phone or other electronic device, if you wouldn't mind putting that on silent. I'm sure the folks sitting around you and the folks who will be listening and watching on video will very much appreciate that, as we will. So let's get right into it here. And what we are talking about is sort of the hot topic of the day, of the moment in EMS. But new times, we are certainly in new times. There is no debate about that. All you have to do is turn on the television, watch the news, listen to politicians, and it seems as if all we are hearing about are discussions about the future of our healthcare system. So, there's no doubt that we're sort of in the middle of that whole debate. And this slide says, of course, I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years. That is not what we want to do. We're not trying to be bold and innovative to do what we've continued to do, and that's a lot of what sparks the trend here in community paramedicine. And the first thing that I think to set the table, and Steve will talk about this a little bit more, that we have to think about is setting aside some of the old rivalries in EMS and healthcare that always existed and sort of gear up for the new ones. Back in the day it was public EMS versus private EMS, right? The for-profits versus the public agencies, the non-profits, the hospitals versus the independent agencies. Well, in this day and age, it's not so much we got to worry about who we're competing with on the public or private side within EMS. For community paramedicine and mobile integrated healthcare, which we'll talk about, who we're going to be competing against are, home nursing agencies and other community health programs that are already in place, clinics, hospitals that are doing these kinds of things. You even see the urgent care center attached to the subway. How much more convenient could it be? Go get something that blocks your arteries and then go get it checked as soon as you're done eating, that kind of thing. So I guess I shouldn't say that all of their food blocks your arteries, right? But some of it. Okay, but we still have to bill you for the service call, right? So the idea here is that, the old thinking is that we are a transport-based commodity. Our unit of reimbursement is a transport for most payers, right? Medicare, Medicaid, most commercial insurance programs. The folks who reimburse us for our services pay us when we take somebody someplace. That makes us a transport-based commodity. And that is a fairly inefficient way to do business, but that is how we do business. Here's the creativity thanks to Medicare reimbursement, right? We'll transport for food. I hope none of you are quite at that point yet with your ambulances. So we're talking about moving much of what we do into a community or home-based setting as opposed to in a transport setting. So we're going to talk a little bit about the evolution of community paramedicine programs and integrated healthcare. Talk a little bit about the dark side. I think there are more qualified sources than us. I will give you this disclaimer on the design of community paramedicine programs and concepts of mobile integrated healthcare. There are other agencies, Steve will mention a few of them later, that are out front on that concept that are doing those things. We're a law firm. We're not an ambulance company. We're just legitimate ambulance chasers. So that's what we do. You folks are the ones that are out there providing the care. But it's sort of our job at these conferences and in the publications and things like that to sort of remind everybody that we have a legal side that we have to contend with. It's not always the most pleasant aspect, thinking about what it is we have to do, but that's going to be our focus here, is to try to address some of the emerging legal issues. And some of these are emerging issues, folks. There are no roadmaps to some of these issues. They're new. They're happening as we speak. And I mentioned this in a talk I did the other day, but much of what is happening in community paramedicine and mobile integrated healthcare is being driven from the community up. And those of you that have been around EMS long enough remember the day, as Steve and I do, when everything was sort of dictated from the top down, right? Here were your state EMS regulations and your protocols, and here were the rules that you had to follow that were all pushed down from a centralized state EMS system. And 20, 30 years ago, maybe that was what our systems needed, that centralized structure. Nowadays, it's really the community level that's pushing this up to the states, which means the folks at the provider levels are out in front, in some cases, of where state laws and regulations sort of allow them to be. Just for the record, I'm fine with that. I think that's how progress happens. And if the bureaucrats and the regulators come along eventually kicking and screaming, fine, bring them to the party. So if you want to say that I'm in the camp of, better to beg for forgiveness than ask for permission, right? You've all heard that statement. To a degree, I subscribe to that. But then the lawyer in me kicks in and says, well, we got to help these folks protect their interests. So that's what we're going to talk about, okay? Some of the roadblocks and legal issues. Then we're going to talk a little bit about what the federal government has had to say about this in terms of compliance. There's a significant opinion that came out on that we're going to talk about, and then some next steps. So, of course, again, you folks know as much or more about some of this stuff than we do in terms of how the delivery models are emerging, but community paramedicine and integrated health or mobile integrated health are the terms essentially for a new sort of healthcare delivery model where we have specially trained EMS providers who go out into community settings, home-based settings, or other places where the patients live or reside, and deliver care in that community setting, not necessarily during transport, but going out and helping preventing these patients from maybe coming into the hospitals or coming into the acute care system. And again, this is something that we see emerging in pockets of the country. So what it does is it's really expanding the reach of primary care. And if any of you in the last month or 6 months or year that have read about community paramedicine programs and mobile integrated health have scratched your head and said, wait a second, is this sort of a new wrapper on an old can of beans? Those of you that remember the push toward expanded scope paramedicine and all those things that were hot in the 80s and 90s, it's not that different, really. It's conceptually not all that different. We're talking about additional training, in some cases, expanding the scope of practice, which we'll talk about, and then going out and providing care in other community settings, not necessarily just in response to 911 calls. Okay? One of the target goals here in these programs is to reduce the utilization and demand on urgent care in emergency departments and in inpatient hospitalization. And there's a strong financial link that can fund community paramedicine programs that we're going to talk about where that comes in. Reduce the length of hospital stays and readmissions, particularly for certain conditions. And the federal government has already started to enforce this, and we'll get into that in a few moments. To reduce conditions, the need to send a patient back to the hospital, and that's what happens. They call 911, they get an expensive ambulance ride, they have an expensive emergency department visit, they end up getting readmitted. But there are some conditions, as we all know, that can be managed outside the hospital and do not necessarily require readmission. CHF, pneumonia, MI in some cases, not one that's currently happening, but patients who are recovering from an MI. So these are the kinds of conditions that the federal government has begun to target, and we'll talk about where there's a financial incentive for EMS in those cases. Okay, so we know that unless we're living under a rock someplace, we know that managing costs in the healthcare system is the theme of the day. It is a theme of Obamacare, the Affordable Care Act that was passed by Congress a few years ago that's now being implemented in phases, and incentives to reduce costs across the board. Now, the silver lining is that payers, particularly government payers, Medicare, Medicaid, other federal and state government insurance programs also have an incentive to reduce costs and to work with providers who come up with innovative delivery models to reduce costs. One of those that has been sort of ingrained into the Affordable Care Act are the accountable care organizations, ACOs, that you might have heard about. Now, we do not detect a groundswell of, there's not people beating down our door to help them write contracts on ACOs. We don't know of a whole bunch of EMS agencies that are integrating into ACOs just yet. I mean, those are starting to emerge. There's some new ACOs coming out every day. But that's one of those models that sort of aligns the delivery of health care that the Affordable Care Act wants to incentivize. So one of the things that is important for all of you is that, and it's important to stress that the federal government has really kind of done its part here. They've passed the Affordable Care Act. Obamacare is being implemented. The rest of the action on how this is going to work at the community level is really not going to be here in Washington anymore. It's going to be at the state level, because that's where your scope of practice is regulated. To some extent, that's where your reimbursement is regulated through your state Medicaid programs. What commercial insurers in your state do and don't have to pay for is all a function of state law. So a lot of the action now shifts to the state level, which means folks have to get organized and participate in their state organizations, their state associations. And later on, Steve is going to tell you about a model in one state where that has worked, and there are community paramedicine laws actually now on the books, first state in the country. I will leave you on the edge of your seat to learn what state that is till when Steve comes up and does his part. So what that means is that we need you, and you folks need to go out there and be the advocates to move this forward at the state level. Again, this is to some extent the tail wagging the dog. We need you all to get out there and wag so the powers that be see us for what we are and the capabilities that we have. And have you reached out to your hospital administrators and other folks to include you in these readmission reduction plans and these other cost-cutting efforts that they're working on, and how you can be included, right? EMS needs to be at that table. His foot in the door technique has to be seen to be believed, right? We've got to get a foot in the door when it comes to working with these facilities. So let's talk a little bit about the dark side, some of the roadblocks, and some of the legal issues. The first one that I've already sort of touched upon are the limitations on all providers at the state level with regard to their scope of practice. And that is first and foremost, the big issue. That the scope of practice that's defined in your state EMS law, or more likely in your state EMS regulations, will define exactly what it is that EMTs, paramedics, and other care providers can and cannot do. And given the fact that most states do not yet have community paramedicine statutes, most EMS offices are probably going to take the position that your scope of practice is going to be judged by what's in your current paramedic regulations or EMT regulations as far as your scope of practice goes. So that's, of course, the first roadblock. Now, some states, and this is something you want to look into, do have mechanisms to allow local medical directors, service level or regional or county-wide medical directors, to expand or vary the scope of practice at the local level, sort of a local option scope of practice. That's the first thing you want to look at. Does your state have something that allows the scope of practice to be extended, modified, expanded at the local level? So you get a progressive medical director who helps you sign on to do these things. Your state law would allow that. If not, if there's no local option scope of practice in place in your state law, then one of the things you may want to be able to hang your hat on is, can we call this a research project, an experiment? Because if you look at many state EMS laws and regulations, they do have provisions that may allow, for at least a period of time, that to be done as an investigative process. Now, there are other hoops that you got to go through for that when it's a research project, but that's another way to look at this to help prove that the model can work. So those are just some other thoughts on scope of practice issues. For some of you that may not have either of those options, then your last option may be you have to go get your state law changed or get your regulations amended or rewritten or expanded if there's the statutory authority to do that, okay? Another roadblock is we all talk at these conferences. We try to be progressive and move the ball forward. We all know that many of the payers, especially the one up the road here, Medicare, our single biggest payer. We can tell them till we're blue in the face how great of a model this is. And I've sat across the table for many meetings with many Medicare administrators. Back in the day, I used to work here in Washington for the federal government in the Department of Health and Human Services. And I can tell you, when you bring them an exciting, innovative, new model for health care delivery that they should start paying for, they will sit across from the table with their arms folded and say, "That's very interesting. We'll be glad to take a look at that." Which is bureaucratic for, "Get the hell out of my office and don't ever ask us for another dollar." Okay? So that is a tough nut to crack, right? And the Social Security Act, which is where Medicare comes from, was written in that part of the Social Security Act, Medicare, was written in 1965, when the primary criteria to be an ambulance was what? Can you transport a person horizontally, right? That was the primary criteria to be an ambulance. So the unit of reimbursement became a transport, and that's why to this day we are still viewed as a transport-based commodity. In fact, in 49 out of the 50 states, Medicare will not even pay for non-transporting paramedic intercept services, which is one of the most common ALS delivery models in the country, because they don't transport. If the ALS service in a tiered system where you have transporting BLS and non-transporting ALS intercept wants to get paid, they have to have an agreement where the BLS service submits the bill for the ALS rate and then reimburse the ALS service at whatever the agreement says, right? That's because Medicare won't pay for things that don't transport patients. So that is what we're up against, folks. The non-transport delivery model of EMS has been around for a long time. If you look at tiered ALS systems as an example, and they don't pay for it in 49 out of the 50 states. Trivia question of the day. What's the one state where they do? New York, that's right. There's a strange little quirk of state law that was incorporated into the federal law that allows non-transporting ALS intercept services in rural parts of New York to bill for their services. The rest of us, what's the legal term? We're screwed. That's the legal term. Okay, so the state law issues, and you got to love this. Nevada, liquor legal 24 hours, gambling legal, prostitution legal, lobsters apparently not legal. I didn't know that. I've had plenty of lobsters in Nevada. I have not had the other things, just in case you're wondering. Okay, so we have to deal with scope of practice issues. We talked about that. I don't need to repeat that in the interest of time. But keep in mind that and this is the problem. It's not just are we geared up to do it, but will your state take the position that you may be putting licenses and certifications in jeopardy if you do these things? So when we say dot the I's and cross the T's, we're making sure, don't start running with your shoelaces untied, okay? Make sure that your state is not going to take the position that the minute you try to do something that even remotely looks outside your scope of practice, they're going to come after your certification or your license. You do not want to go down that road, okay? Because there are penalties involved in many of those state laws. So we also need to advocate for broader and less restrictive EMS laws and regulations. I wrote a piece on this in one of the publications a few months ago, sometime last year, sort of arguing that we need to kind of rethink the way we regulate EMS. And you are talking to a former county EMS director, regional EMS director, state-level EMS guy, and then I worked in Washington before I went to law school. So I was Mr. Government EMS regulation kind of thing. But back in the day, 80s, 70s, 80s, think about our medical directors back then. How many dinosaurs do we have in there that remember these days, right? How many of you are lying but really were around back then? Okay. We didn't have that many emergency medicine trained medical directors. There weren't that many medical directors that came up through the ranks as EMTs or paramedics and understood pre-hospital care. Medical direction in many communities were well-meaning family physicians or general practitioners who signed on to be the medical director of their local nonprofit ambulance service, right? So as a result, having things centralized in state protocols and regulations, controlling the practice of EMS made some sense. We've got a lot more qualified medical directors out there these days. Not everywhere, I understand that. But we've got emergency medicine trained physicians out there. We've got physicians who have done EMS fellowships out there as a subspecialty. There are physicians out there who have come up through the ranks in EMS. The fact is that they understand pre-hospital medicine much better than they used to, and evidence-based medicine. Why do we have to so tightly control everything at the state level when the medical directors at the local level, by and large, are making much better medical practice and control decisions than they did 30 years ago? The drug shortage is a perfect example of that. We've got certain medications, solutions that we can't get. So we're forced to use outdated, expired medications or find workarounds. Why don't we just write it up in a sentence? You need analgesics, you need diuretics, you need this, you need that. Give them some categories. Let the physicians look at what medications and substances make the most sense, the ones that are available, the ones they can incorporate into their system. We don't have to tightly control every Band-Aid and 4x4 that goes into a jump kit, is my point. Okay? So rethinking and challenging those paradigms of this tight control from the top down to allow the flexibility at the community level. This is community paramedicine, not state paramedicine. Okay? So if we can advocate for state regulations, protocols, scope of practice legislation, to give that flexibility to qualified local medical directors. If you don't have a qualified local medical director, fall back on your state protocols. But if you do, then you should be able to build a system that meets the needs of your community better. That is my soapbox. I will climb off of it and move on. All right. The antiquated Medicare model, as we've talked about, again, we're a flat fee per transport commodity. That is a nut that will be very tough to crack going forward. But the Affordable Care Act does encourage new models to improve outcomes, and community paramedicine programs can tie into this new approach. Now, what I want to talk about here for a moment, after I take a sip of water, is a federal law that is something that scares most healthcare administrators, and that we spend a lot of our time advising clients on compliance. And that is a federal law called the Anti-Kickback Statute. And that law prohibits one party, one person, from giving anything of value, whether it's money or anything else that has value, to anybody else to induce them to refer patients to a person or an entity that gets paid by Medicare or any other federal health care program. Okay? So when you hear the name of this law, Anti-Kickback Statute, you may think, well, this is two people in a dark, alley exchanging a cash-stuffed envelope, That's really not how the Anti-Kickback Statute usually works. Of course, if you're a provider and you give somebody $20 every time they use your ambulance service in unmarked envelopes, that is violating the Anti-Kickback Statute. But it happens in other ways, and we're going to talk about that in the context of the Hospital Readmission Reduction Program, or HRRP. This is another provision of the Affordable Care Act that penalizes hospitals who have excess readmission rates for certain identified conditions. This year, the penalties go up to 3% of the hospital's Medicare reimbursement, which in some systems is a significant seven-figure chunk of change. Okay? Now, currently there are 3 conditions on the list. That list will be expanded by the Department of Health and Human Services. And what the list says is if you have a patient who is discharged with one of these 3 conditions, one of these 3 diagnoses, AMI, heart failure, or pneumonia, that if that patient comes back and is readmitted in your hospital within 30 days, we are going to penalize you up to 3% of your Medicare reimbursement for those readmissions that are deemed to be preventable. Now, folks, we are going to see that list expand, and there are other conditions I'm sure you all can think. What are some others you can think of right off the bat that can be better managed outside the hospital? Diabetes, COPD, perhaps. So there are other conditions that no doubt we will see on this list, maybe post-orthopedic cases, ones like that. So we're going to see more conditions, but right now these are the 3. So it's not a big, massive, unwieldy federal mandate. We're talking about 3 conditions starting now that the hospitals have to reduce the readmission rates. If the patients bounce back into an inpatient bed within 30 days, the hospital gets penalized. If they get penalized 3% of their Medicare reimbursement, and we're talking about $1 million or more, whatever that could be, a couple $100,000, the point is it's a pot of money, right? And those hospitals are going to be looking for ways to work with other community resources to keep the patients out of the hospital. If they can. If a patient needs to go to the hospital, folks, we take them to the hospital. Let me please stress that. But for patients who really can manage, and a lot of this, if you think about it, is patient education, compliance with treatment plans, keeping appointments, refilling prescriptions. These are the things that many patients with these conditions do not do a good job of. So if a community resource exists to help hold their hand and walk them through that management process, a disease management process, maybe these patients can stay out of the hospital and save the hospital's money. So now there's a pool of money. You're a hospital. You can either pay Medicare $1 million or whatever it is in penalties, or partner with a community health resource to keep these patients from coming back and not pay $1 million fine. And I'd rather pay a partner to help go out in the community and keep these patients healthy, right? So now there is a financial incentive. Even though Medicare doesn't pay us for community paramedicine, the hospitals are going to have to pay a bunch of money back to Medicare unless we or somebody else can help keep these patients out of the hospital. So here is some good news from the Office of Inspector General. If you have ever been to one of our presentations, you usually see us up here harping about some opinion or the other that the OIG issued that makes life difficult for EMS agencies. This one helps us out, but it's not in EMS. There are other agencies beating us to the punch of where we should be. Okay? This is Advisory Opinion 13-10, and you can find all of these OIG advisory opinions very easily, either on our website or at the OIG's website. You type in OIG advisory opinions into Google, and it'll take you to their site where they list them all. This was released just in August of 2013, so a few months ago, and it was the first OIG opinion to be released on this idea of the hospital readmission reduction program and partnerships with agencies to help keep those patients out of the hospital. Now, in this case, again, it was not an EMS agency. It was a wholly owned subsidiary of a pharmaceutical company. So the plot will thicken in a moment when we talk about what they do, that has technology and services to help coordinate care, help patients adhere to their discharge plans, and reduce those avoidable readmissions. So what happens is when a patient is scheduled for discharge, the nurse who is handling the discharge identifies the patient who meets the eligibility criteria to participate in the program, has one of those conditions that we talked about. They explain the post-discharge services that are available to the patient, and if the patient says, yep, sign me up, sounds good, then the discharge nurse uses the technology platform that's provided by this company to upload all of the patient's information. Then that notifies a patient liaison from this company who goes out and starts working with the patient. They remind them of their appointments. They help them obtain transportation. Ding, 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 ding. And they remind patients to refill their prescriptions. When you're wholly owned by a pharmaceutical company, that could be construed as a kickback, right? That's where this law comes in, and the federal government therefore had to review this case. Now, if this liaison that they send out thinks the patient needs to go see a healthcare provider, they refer them to the one that was designated by the patient. But if we start referring patients to providers, that too can raise anti-kickback concerns because this company is getting paid to do that, right? So this is why this law, this federal law, is a concern in these cases. Now, this company is paid in three ways. One is a flat fee that the hospital pays when they sign up to become a customer of this company for the technology platform and to get them enrolled and all that. Then each time a patient signs up, they pay them a per-patient fee. And then there are certain additional services that they offer that they can pay for on an hourly basis. So it's a three-tiered model. Here's what the OIG said. And this is bureaucratic ease, and I'll translate it in a moment. Although the proposed arrangement could potentially generate prohibited remuneration under the anti-kickback statute, if the requisite intent to induce or reward referrals were present, the OIG would not impose administrative sanctions in connection with the proposed arrangement. Only in Washington can they write a paragraph like that that says, it's okay with us, go forth and multiply, right? That is what they're saying, all right? They're saying, look, we know you're paying money and they're referring patients to you, but we're not going to come after you under the anti-kickback statute because this is what we want you to be doing. All right? Now, they said that for a couple reasons. Number one, this won't increase costs, which is what the anti-kickback statute is meant to prevent. It's going to encourage appropriate utilizations, reduce readmissions, and hopefully save money. Second, they don't see this referral arrangement as influencing clinical decision-making, because when a patient needs referred to a healthcare provider, they're going to go to the ones that they themselves designated in their record, right? Third, there are safeguards in the program. Because this company is owned by a pharmaceutical manufacturer, they wrote some safeguards into the program so that those patient liaisons can't go out and, say you got to refill your prescription with brand name medications and not generic medications, right? So there are safeguards that the company worked into that, so it's not just seen as a way to steer patients to the use of this company's products, okay? And fourth, they said, we don't think this is likely to steer patients to one provider or another because it's their choice. So at the end of the day, that is a happy-face green light that for the first time, just in August, the OIG approved this type of arrangement. Now, obviously, this was not an EMS agency, but it is exactly the blueprint for what mobile integrated health and community paramedicine programs could and should be doing. This is our lunch they're eating, put another way, right? So the fact that these OIG advisory opinions take a year usually to be issued means that other parts of the healthcare system are way out of the gate. And some EMS agencies are too, and Steve's going to talk about some of them. But in some communities, you're going to have to play catch-up. But the implications here, again, is that that model provides a blueprint for what we can and should be doing. And think about how well-positioned we are. I hope that was apparent when we listed what that company was doing for this hospital. Going out and providing patient education, helping them comply with treatment plans, making sure their medications are stocked, arranging transportation when they need it for appointments and hospitalization, which the hospital hopes they don't need. But this is where, again, the idea of mobile integrated health comes in. We can do these things probably better than a wholly owned subsidiary of a pharmaceutical company can do it. Okay? So we're already a participant in that patient's continuum of care. They know us. There's a statistical possibility that they got to that hospital in the first place in one of our vehicles. Okay? So when they see us at their door in a home-based environment, they know who we are. So we've got some advantages that are sort of built in. All right? So this is a positive step. It's a positive development, but those are not the only challenges. So I'm going to turn it over to Steve now, and he's going to talk about some of the other obstacles and opportunities inherent in community paramedicine programs, virtually right on time.
Thank you.
You're welcome.
You're only 2 minutes late. That's
great.
Okay, great. Well, let's talk about the opportunities, because this is really where we're at in terms of changing the whole mindset of the way we've been thinking. Fire departments, for example. What's that old phrase? The fire service, 200 years of tradition, unimpeded by progress. Thinking outside of the box. That's what makes these whole programs successful. And as an example, Snohomish County Fire District Number 1 in Washington State, north of Seattle, fire department-based EMS. They're implementing a community paramedic program. They met with their local hospital. The heck with all this, funding for the moment, all these other options. The hospital recognized right away the impact that it can have on them. They said, we'll pay for it, because they know they want to keep these folks from coming back in who've been discharged. They don't want them back within 30 days. So it's interesting. It's not just ACOs. We think, frankly, there's going to be more of this direct contracting between you and your local hospital. You don't have to wait on an ACO or be a part of that necessarily. Okay? Pretty cool stuff. A pessimist sees the difficulty in every opportunity. An optimist sees the opportunity in every difficulty. And sometimes, we're a victim of our own closed-minded thinking. Okay, we are. Let's face it. We all know that. We're here. We're learning new things. But a lot of times, we don't look to other industries to see where we can learn. Okay? If it wasn't done in fire EMS, well, we can't do it then. And that's like the OIG opinion that Doug talked about. I mean, there's an industry, it's healthcare, but it's not EMS, but that's a great roadmap. Now, you can be very realistic about being a pessimist and a realist, but you know, I'm half full, I'm half empty, or be really realistic, okay? Okay, the ultimate reality check, I guess. That is a funny slide, actually. I thought it was lemonade, actually. Doug mentioned the turf battles, and yeah, you know, it's amazing. It used to be, you know, the private EMS provider versus the public EMS provider. Now, talking to some folks here today, they said, gee, we're getting these calls from senior services. They want to meet with us. What's senior services? Well, they're the folks that also have RNs that want to go out and take care of these folks out in the community. That's who they are, okay? Or home health agencies and so forth. So you've got a lot of others that are starting to look at this. And unfortunately, they're, in a way, a little better positioned than us initially because they're already integrated into the hospital system because there's referrals, discharge planners, and all, call that home health agency. You know, they'll help. So we got to make sure we get in, as Doug said, and meet with folks right away. The folks in Snohomish were very surprised. Their very first meeting, the hospital administrator said, we'll pay for it. Okay? Wow, that was easy. Okay, you got all these other providers out there. And they may not be as supportive initially. What if your hospital owns the home health agency? Okay? Or they have a department that operates it. So you've got some of those issues to just think about as you move forward in meeting with those folks. But you know, the reality is the Affordable Care Act is really pushing this value-based purchasing. That's going to open doors. This readmission penalty, that's going to open doors and so forth. So you've heard this word, collaboration. You know, that's really the buzzword. You know, you need to really get integrated fully into your community. Literally inject yourself into that meeting with those administrative people at the other healthcare institutions. Get a seat at the table. Show them that, you know, we're not here to take the whole pie, but we can provide a good portion of services that you are not able to do. You know, when you think about who is best prepared to do community paramedic programs, it's us, right? We got vehicles on the street. We're mobile. We got trained personnel who are certified. We already operate 24/7. We've got a medical direction system and protocols and procedures. So we're actually, from a technical standpoint, an operational standpoint, better prepared to jump into this game as compared to some of these other agencies. So, you know, and then there's this other angle to it, public acceptance, which we haven't really talked about. Let's face it, you know, how many times do you go on a call, okay, and you get an elderly person, and they ask, are you a doctor? You know, I want to talk to the doctor. I want to see the doctor, you know, that type of thing. Sometimes you can convince them to go to a hospital if you put them on the phone with the doctor, you know, because that's the traditional model of healthcare delivery, okay? So we need to make sure that the public understands how this will work, that it's not going to deprive them of their 911 emergency ambulance if they need it, okay? And sometimes we, you know, if we get the public behind this, and we're also greatly positioned for that because we're out there in the public eye all the time. So we've got sort of the channels already with the public. Now, you know, I remember back in the days, late 1970s, when I first became a paramedic, we literally had to get to the scene before this guy did because he was at a scanner, he was listening and going with his black bag to calls, you know. He'd show up at a cardiac arrest with a black bag, okay? Where's the defibrillator in that thing, buddy, you know? And that's the whole thing, you know, trying to integrate this new model to gain acceptance and show folks that we need to shift the way healthcare is delivered. So retooling your public education program, perhaps. You know, we do a lot of community CPR training, AED training, all that kind of stuff. Those are good ways to sort of introduce it. And think about spending a little more money on this, okay? Some additional resources to get this public response that you need to have to really integrate this into the community and work with other agencies as well. So you want to show them that, look, we're already rooted in accepted medical practice. This is not just a bunch of you know, fly-by-night people running around in vehicles, okay? We're trained professionals, okay? It's evidence-based. We measure and improve the quality. We have medical direction. We have protocols. and we have great technology to do all this stuff. So, you know, this helps with the public in terms of letting them know that we're providing good quality medical care under this model. It also helps with the hospitals and other agencies so that they know that we're providing that same high level of quality care that they provide as well. So, running with your community paramedic model. Yes, here's the state. Can we all say it? Minnesota. Minnesota, right? Anyone from Minnesota in here? Okay. Okay. It's too cold up there to come down here, I guess. I don't know. Anyway, that is the state that Doug was alluding to that has made major headway. And what they've done, they've literally put a law in place that approves community paramedic programs. And the key thing beyond just the actual approval process and how it's going to work, okay, the structure of it is they get their state Medicaid program to pay for it, okay? Now, we all know that Medicaid generally isn't the highest payer in terms of money you get, okay? But it's a start. It's better than, you know, trying to get, you know, blood from a stone, okay? And by having a significant payer, the state Medicaid program, pay for some of this, okay, others may get involved and want to pay for it, okay? So that has really helped a lot, and it's really grown. And it was a grassroots effort that took the folks in Minnesota several years to accomplish, okay? And fortunately, they got some very good people up there that were involved in this, Gary Wingrove, O.J. Doyle, a bunch of other folks involved who really pushed all the right buttons and got the community involved and got the legislators involved. They started in 2011 was when the legislation was enacted, and they have a certification. It's called Emergency Medical Technician, CP, Community Paramedic, okay? And it authorizes the medical assistance program in the state of Minnesota to cover these services, okay? Now, did it happen overnight? No. Was it easy? No. It took a lot of collaboration, as we mentioned a moment ago, working together with legislators, hospitals, others throughout the state to make sure that they were defusing some of the potential opposition. Now, they initially weren't prepared for that because they were early into this, and they were a little surprised initially that, you know, they got some resistance from some of the traditional healthcare groups, okay? Imagine that. Suspicion and concern and that kind of stuff. They didn't really have a clear understanding of what paramedics do, okay? We still have that problem today, don't we? You know, they don't know what we do out there and the life-saving things that we can bring to the bedside and to their home and so forth. So there's education that's required as part of this community paramedic certification. And we basically needed to convince, they needed to convince the public and the legislators that this was a natural extension of what paramedics already do, okay? So that they were able to accomplish. And they worked closely with the educational system there. Hennepin Technical College was the first college in the United States to offer certified community paramedic training program. It's 112 hours of classroom instruction and 64 hours face-to-face or interactive, 48 hours online, 196 hours of clinical training, which they bring to the community, arranged in your own area because, again, it's a community paramedic program. And the role encompasses all these things, everything from outreach, wellness, health screening, all the way to wound care, safety programs, extension of physicians into rural clinics and hospitals. So lots of training, good training. This program has been well received by Minnesota. And ultimately, basically, when we craft legislation like what they did in Minnesota, we really need to make sure we engage all the players. We engage all the constituents, those who have an interest in this program. So they have protocols established, standards established by the EMS medical director, and the services that are actually provided in the field, if you will, are part of a patient care plan developed by the patient's primary care physician or other health professional, along with the EMS medical director and local health care providers. So there is like a care plan. People get approved for this program. The coverage under medical assistance, to look at just that. Subsequent legislation to identify those reimbursable services didn't come right away. Took a little bit. They finally got it enacted. And to be eligible, a recipient, that's the patient, okay, The patient has to be an individual who received emergency department services 3 or more times during 4 consecutive months in past 12 months. Sounds a little complicated. Or they're an individual that the primary care physician determines community paramedic services would likely prevent admission to or would allow discharge from a nursing facility or would likely prevent readmission to the hospital or nursing facility. So that's where a lot of the patients are coming under this definition here. So what's covered under the Medicaid program in Minnesota? They just published some specifics in their Medicaid manual. You can find that online. It's pretty easy to find. Just looked at it the other day. But they will cover health assessments done by community paramedics, chronic disease monitoring and education, medication compliance, which is very, very important. The studies show that a lot of people get readmitted for the same conditions simply because they don't follow their discharge plan. They don't take the meds. And just having someone check up and make sure and review. I mean, imagine being, 89 years old, a little dementia going there, and they give you 30 different pill bottles to take, Which one do I take? How often? That kind of thing. Immunization and vaccinations as well, covered services. Laboratory specimen collection, hospital discharge follow-up care, and minor medical procedures approved by the ambulance medical director. These are the services specifically outlined in the Minnesota Medicaid manual as to what they will cover as part of the reimbursement process here. They won't cover travel time, mileage, facility fee, or services related to hospital-acquired conditions like infections and that sort of thing. They don't want to pay for that because they believe the hospital should pay for that, as does Medicare. Okay? So that's the services that are not covered. Now, how's it billed? They basically have to have your enrolled medical director. Your medical director of your service in Minnesota has to be enrolled in the program, the Medicaid program, and basically the billing is done through that physician's number, okay, basically. And it's encounter time with the patient. That is a common way that physicians and a lot of healthcare providers bill by the time we spend with the patient. We don't do that under the traditional transport model, okay, but this is how it is normally done with physician office visits and so forth. And there's varying degrees of complexity of the visit and all that. Well, here in Minnesota, they're billing that encounter time with the patient in 15-minute increments, and supplies primary to the encounter that are related to that encounter with the patient can also be billed and covered as well. So that's the gist of it. They're just now in the process of getting that whole thing going. It took some time getting the appropriate waivers and approvals from the federal government in terms of modifying the Medicaid plan, because every state plan has to be modified, or you have to get a waiver when you change things. So make sure you do your homework. Determine what model makes sense for you, and then pursue a comprehensive plan to promote and facilitate implementation. Now, just a couple quick points. As Doug talked about the need to change legislation, there's a big roadblock potential there. But that's not true in every state. Minnesota, they needed to change legislation. We know a lot of states where you would. Washington State, they didn't need to. The legislation was written broad enough to allow for more local control and medical direction and so forth. So it depends on your state. Your first step is to go back and see, hey, can we do this kind of thing? Okay? Can we do this? And under our current state law. And if not, then obviously we need to look to making some changes there. So identify the initiatives that effectively use your EMS provider skills and provide that appropriate expanded scope of training to qualify them to participate in these programs. And you got to make sure you have good medical oversight, plain and simple. That's true of anything we do in the field, generally speaking, but particularly so when we're getting into this new realm as well. So you got to convince your state legislatures to deal with the antiquated laws that are out there. There's also some laws, too, that are protectionary laws, if you will, for nurses and other healthcare providers that have specifically limited the role of paramedics to very specific EMS system-defined activities. So you got to check that out, too, because about 20 years ago or so, when there was concern about paramedics working in ERs and other places, non-traditional places, some states passed some restrictive laws there. Opportunities to exist or to partner with hospitals, ACOs, and managed care programs, insurance companies as well. certainly there's several different avenues you can go down. It depends on your community. Some folks I've spoken to here in the last couple days have said, well, we already have community paramedics. We're in a rural area. We've already been doing it. We may not charge for it. We may not bill for it. But we're already doing that to an extent. So you really got to look at your own community and see where you want to go with this. It's really, there's no such thing as one single model to use, okay? And it's important that it be adapted to your community. Behind every good doctor is a great physician assistant. Okay, very good. Lots of other healthcare providers, all right? The point of that slide is that there are other laws, too, that may allow for this under state medical practice acts. In a lot of states, physicians are allowed to direct anyone, basically, that they train to perform certain services on their behalf, okay? In Pennsylvania, for example, we had paramedics working in the OR assisting in intubation procedures and so forth. Not under the EMS Act, but under the Medical Practice Act, okay? So they were taken under the wing of the physician, if you will, and being taught specific things. There are states that allow for that kind of thing. So that's another avenue to check in terms of state law. You might have some flexibility with your Medical Practice Acts as well. So get a presence in your state capital. You've got to really understand the legislative system. O.J. Doyle in Minnesota is very good. He's been involved in lobbying efforts and things of that sort on the Capitol Hill of Minnesota, if you will, for many years. So he had a lot of good connections there. Don't assume that people know what you do. As we said at the beginning here, we have a vast array of folks out there who have no clue what we do. And now, especially when we want to change and add a new program, it's ever more important to do good education with all those folks who have an influence on where this program is going to go. So meet with those who might oppose or support. Don't ignore those that are, you see as competition. Meet with them as well. Get a sense where they're coming from and let them know that you're not there to take the whole pie. Maybe there's opportunities to work with them as well. So there's lots of things that you can look at and, pointing out that you're here to supplement, not replace the existing healthcare services that are in place. And as they say, there's two things you don't want to see being made. Sausage, for one thing, and the law, okay? You don't know what goes into it. And it's a process that all this behind closed doors, behind the scenes stuff that goes on in making new laws, it really is an interesting process. And anyone who's been familiar or involved with it know that it can get pretty ugly, and sometimes you don't want to know how that sausage was made or how that law came about. Some people have criticized the Affordable Care Act and other statutes because, legislators didn't even read it, got pushed through and that kind of thing. So you just never know. But the point of that is identify those legislators who are very good at moving legislation, okay? Some of them may have personal experiences with EMS in your service. That can help a lot. Give them specifics about how you want to approach this, the type of training, certification, and regulatory oversight that you would like to see happen. And, of course, lobby to get additional sponsors. Count the votes, if you will. Okay, anyone remember the hanging Chad from many years ago? You want to know where the support lines up and where it doesn't line up, and work on those who are on the fence. It's the old story. If you're dealing with 100 legislators and you got 30 of them totally in your camp, you probably don't have to waste your time with them. Okay. Maybe you got 20 that are on the fence, and then the others oppose. Work on the 20 that are on the fence, because they're the ones that are going to push it over the edge into the majority category for a positive vote for you. So, talking with the governor's office, depending on your state, the governor may or may not have a lot of influence with the state legislature. I'm not sure how things are for Governor Christie in New Jersey. You guys know? Just kidding. But things vary, and there may be a very good relationship or maybe a not so good relationship. But you got to have patience. It takes time to get this stuff going. And look at your state law first. Talk with your medical director. Maybe you got some flexibility in your current state law, and maybe you can get this thing going a lot quicker. Like I said, with the folks up in Washington State, meeting with a hospital, they're already paid for it. Okay, that saves a lot of time and effort too. Oh, the bandwagon approach. jumping on the bandwagon is not always the best of choices, like in this case. We've seen some really bad crashes here with this lousy weather the last few weeks. But the point is, once you get like the state Medicaid program on board, that's a big thing. You know, that's a big deal. And other insurance companies may look at that and say, hey, that legitimizes what they're trying to do. If the state approves it, my goodness, maybe we should too. Okay? So that really helps a lot. So we expect to see in Minnesota and other places that do this sort of thing, really getting a highly visible program, getting good legislation, and getting maybe state Medicaid to pay for it to start may help in getting other insurers and payers to pay for it as well. So that's what it's all about. Here's some sources for this information. We're not directly involved in the Minnesota situation, but we know of it pretty well. And there's some sources there and contact folks that you can talk to. North Memorial Hospital was really one of the catalysts in getting this involved, getting this going in Minnesota. And there's some contact information there if you'd like to jot that down. These guys are really helpful and willing to certainly talk to you. And here's some folks who are here today at EMS today. Talk to the folks at REMSA. They're here. They got a multi-million-dollar innovation grant from CMS, a 3-year project to implement community paramedic programs in Reno, Nevada. MedStar in Fort Worth. Matt Zavadsky is here and his folks. They've done wonderful work there. Snohomish Fire District number 1, they're here from north of Seattle. And Chris Montera, Ann Montera from Eagle County Paramedics in Vail, Colorado, they're here as well. These are just some of the folks we know. There are more here, I'm sure, who are involved in these things. These are just the folks that we know are here at EMS today. So, quick summary here as we wrap it up. These programs really do hold a lot of promise for us in terms of looking at alternative revenues, reshaping the way we deliver care in the community. Because let's face it, it's all about the community. We are public service. That's what we do. And if there's ways we can help the public differently to meet a need, well, that's a good thing. So take a look at the needs in your community. Anticipate some opposition and work on that. Get your ducks in order, if you will. Do your homework. Make sure people are educated about the benefits that the patients will receive, the savings to the cost of the whole healthcare system. Tell them how these services are going to supplement and not replace what's already in place, and pursue legislation if it's needed. So, with that, just wrapping up, I think of Churchill's quote, "We make a living by what we get. We make a life by what we give," and you all give a lot every day in your communities and don't always get a lot in terms of pay in return for that, but you don't do it for that reason. And here's another reason, another way that you can give back to your communities through the community paramedic program. So that's all the explaining we have to do. We cannot explain why the cats have spots on them. I'm sorry, someone else will have to explain that. But if we have any last-minute questions, we got some products available and so forth, and our conference coming up in the spring, and you can sign up for the free EMS Law Bulletins.
So we have just a couple of minutes, about 5 minutes left. We can take some questions if there are a few. Yes, sir?